Welcome to this screencast, Arthritis Below the Belt, made in collaboration between Arthritis SA and the Continence Foundation. This screencast is about surgery and continence issues, and our presenter is Dr. Ashani Couchman, who is a urological surgeon.
Good afternoon, everyone. Excuse me being slightly short of breath. I did a little dash from the car park and it turns out I'm not as fit as I thought I was. It wasn't even that far a car park, really, anyway. So I've been given the dubious honour of speaking about surgery in the context of incontinence, and really I think the biggest and most important thing to take away from my talk is that you consider surgery when the basics are done, because I think if you do the basics well, and I feel like you must have had a discussion about dietary modification, about pelvic health, if you do that well, there's a huge proportion of you that may never ever need to come and see a urological surgeon. And I think really it's an important thing to remember that if we do that well, you might not need surgery, but if you do that well and you do need surgery, you're in a better spot because your recovery is that much better. I just should warn you that some of the content might seem a little bit graphic. I've tried to make it as cuddly as possible. And if you feel like it's a little bit gross, close your eyes. Or just kind of go, what is that? And I'll answer. So let's get started. So what is incontinence? Everyone knows that. It's the sudden, urgent loss of urine that is in a space that you're not happy with. So if you're weeing yourself, you're incontinent. If you're pooing yourself, you're incontinent. If you're doing both of those, you're doubly incontinent. Is it common? Very. There's a really interesting statistic from a study done by Deloitte, probably about 6 years ago, talking about a number of people sitting in a GP's waiting room. So in that group of people, approximately 25 to 30% will have a continence issue, which is extraordinary, isn't it? That's 3 out of 10 people. And if you think about the cost per year to the health dollar with incontinence, we're talking about hundreds of millions and not tens of millions. And that is the cost of the equipment you need to keep yourself dry, be it a pad, a catheter, changes in clothes, loss of income because you're leaving work early or preferring not to get out, and loss of social interaction and the emotional and physical results of being incontinent. So it is a significant issue, it's a worrisome issue, it gets people really down and gets families very stressed, and there's something that we can do about it, and we can do that together. So when you talk about surgery for incontinence, how long is a piece of string? So I've tried to break it down into some broad categories and then sort of talk about them in those categories in the hope that that makes a little bit more sense in context. So when a urologist or anyone in continence talks about stress incontinence, what we're talking about is leaking generally when you cough, sneeze, lift, walk up a steep cliff, do any exercise. And that's to do with the lack of support at the lower end of your bladder to keep that water in when the pressure is quite high pushing down. And when we talk about urge incontinence, as the name implies, it is when the bladder is overactive or irritable. So it will independently squeeze, you will feel a sense of urge, and in some people that can result in a loss of urine or incontinence. Nocturnal polyuria, this is something that most people as they age may experience to some degree, and that's when you produce more than a third of your urine at night. So that might show as wetting the bed at night, waking up repeatedly at night, and that's important because there are a few fluid-related factors you can do to change that, to try and reduce the volume that you're putting through at night, which might save you a few more hours of waking up. And finally, overflow incontinence. And that's when, if you imagine your bladder is like a bucket, and that's as much as it can hold at a given point in time, and it really depends on yourself as to how big your own bucket is. If it's full, it'll leak over the top. So if your bladder can only hold 200 mils, and put it into context, most bladders hold about 500. At 200 mils, at 250 mils, that extra 50 mils will leak over the top because you don't have the capacity to hold it in. Now, lots of people don't naturally fall into those perfect little boxes because none of us are like that. You'll have a combination of all of those 4 things, or 3 things, or 2 things. So when we talk about surgery, we need to try and address the most prominent thing that's affecting you and affecting your quality of life, and then address that. So just a few basics. I thought I'd touch on the basics because I think they are so vitally important. Behaviours. Any thoughts on behaviours that can promote continence? Stunned silence.
Yeah.
You're thinking good? So if you're peeing a lot at night, producing a lot of urine at night.
Or drinking too much at night.
Correct. So that's a simple behaviour you could adjust. The number of patients that come to me and say, I have my cup of tea before I go to bed. And I'm going, no, don't do that. If I do that, I'm up at night twice. Caffeine, it's an irritant to the bladder and you produce more urine with it. Quite apart from that, it's quite important to look at how much you're drinking. You know, a big glass of water, that's a big fluid challenge just before you go to bed. And, or perhaps a big glass of wine. Now, I never say don't drink wine because I think life is too short, but you might want to think about when you do that and how much you do that. Maybe it's a lunchtime wine you want and not an evening wine. Foods. Any thoughts on what foods might promote good continence and what you might want to think about? Your bowel and bladder are intimately connected. So if you've good healthy diet, good amount of fibre, good regular bowel habit, that will promote bladder health. So food is very important. Some people have slightly irritable bladders that are set off by certain foods. I have patients who are set off by things like capsicums or tomatoes, so red fruit and vegetables. Something in the skin of that red fruit or vegetable actually causes an irritation. Acidic foods, maybe lemons, limes, that sort of thing, grapefruit, that can set off a little bit of irritation as well. And often they might say, oh look, I get a bit of burning, I get a bit of discomfort, and I do a wee, I feel a little bit better, but I do get a bit of pain in the water pipe as well. So think about what your diet might be on those days where you think your bladder is misbehaving a little bit more, and think about what you might do to change or adjust to that. And actually, the only way to do that is to do a food diary and write it down, because I don't remember what I ate yesterday. There was a chocolate egg in there somewhere, but yeah.
That's bad for the bowel.
So bad, but so delicious. Drink. Drink's a really interesting thing, you know. When you are losing a lot of water, it is very common and completely understandable that you don't drink very much. Because it's particularly if you're heading out in the afternoon or the evening and you're worried that you might need to go a lot of patients will just say, look, I stopped drinking leading up to that appointment or that outing with my friends. I think it's very difficult to say you need to drink more, because if you're leaking a lot more, you're then making it much more difficult for the person to interact in society. But it is good to be circumspect about it to some degree as well. If your urine is very, very, very concentrated, the urea in your urine can be very irritant on your bladder as well, which can prompt you wanting to go a lot more. It can also make you feel a little bit more uncomfortable. So it is better to be a bit hydrated. Quite apart from that, if you're dehydrated, your bowels tend to follow suit, and you end up with a little bit of constipation, which then feeds into your bladder. So that can be a real bother, and you can probably ameliorate that to some degree if you try drinking more. I had a patient who came in who said, I drink really well, I'm very good at drinking, I drink about 2 bottles of sparkling water a day, at which point I just went, oh no, because sparkling water it's very acidic, little carbon dioxide in it, and I think that just increases your bladder irritability. And so, annoying as it may seem, I said, well, can you stick to boring old water? There's nothing bad about it. If you really hate the taste of it, try adding some mint leaves into it. Grab a couple of raspberries and chuck it in. Put a slice of lemon in it. Something that might take away from the taste. But what you just want is a little bit of water. Not gallons of tea, not gallons of green tea, white tea. All of them have the same amount of caffeine. I know I harp on about that a little bit more as time goes on. And exercise. How do you think exercise fits in to us being continent or dry?
Strengthens the muscles.
correct. So at a baseline, strengthens your pelvic floor, and so those patients with stress incontinence, that really actually can fix the problem. You would have had Sonia Sharpeling speaking to you about it. Complete sense, you know. The other thing is, if you are carrying a little bit of weight, that can add to the stress on your bladder. So actually try to lose a little bit of weight can actually improve how well you pee and improve your level of incontinence. And so exercise globally can be helpful, as well as targeted exercises looking at your pelvic floor. And with your pelvic floor, we always say, oh, you know, when you talk about exercise, you say, oh, I'd really like a personal trainer. Because, you know, they'll make you go, da-da. So what you really want for your pelvic floor particularly is a personal trainer for your pelvic floor. And that is your physiotherapist. And that is for boys as well as girls. Everybody has a pelvic floor. And I found that until I went to a physiotherapist and I operate on the pelvic floor, I wasn't doing my exercises as well as I could do. The other good thing is, if you are having any incontinence issues, you can speak to your practice nurse at your GP or your GP and do a continence care plan with them, which gives you access to 5 allied health appointments, which will encompass a physiotherapist. So you can actually access that for free to sort of get you started on what to do, how to do it. And I say, once you know how to do it, it's about picking your favorite program every night and every ad break doing it. And I think that's kind of a good way of making sure you don't forget to do it. Does everybody know how to engage their pelvic floor? Say must. Caffeine, a little bit of a moan here. It's the bane of my life. People don't even know they're drinking that much until they have to write down what they drink, which is what every single patient that comes to see me has to do. To write down everything they drink and how much for 3 days. And it's extraordinary when you say, do you realize you drink a litre of caffeinated beverage a day? Very easy to do, because that just might be 3 really big cups of tea, 3 big cups of coffee. And it's interesting when you look at how much caffeine is in your tea versus the coffee. So that's the equivalent. So green, white, any sort of tea, bar the fruit teas and herbal teas that clearly state they don't have caffeine will have a level of caffeine in it. Decaf will be 5% caffeine. So the best option really is water, which is really boring, but very good for you.
Doesn't cost you anything.
It's free. That's right. That's right. I've started having a lukewarm water at night. This is how boring I've become. But it's a nice replacement to a hot drink, which is quite comforting, particularly in the evenings. Exercise, do that, and water. So those basics, really important. If you do that well, you may never need to see me, which is great, right? Don't want to see me.
Save your money.
Yes. That's right. You can see me in public and I'm free. So what are the next steps once you've done that? I'll just really skip past these, Medication is the next thing, which can support stabilizing your bladder. So that's really more for urgent, overactive bladders rather than stress. Physiotherapy we've talked about. There's new evidence that acupuncture done well can actually improve your urgency, sense of urgency. It's amazing what Chinese medicine understood 2,500 years ago compared to what we know now. And of course neurostimulation, and that can be done with acupuncture needles at your ankle with electrical stimulation, or centrally by placing a little box in your back, which we'll talk about in a bit. So when do we consider surgery? When we've done all our conservative management options, and where you still feel as a client or a patient that you're unhappy, you're unsafe, you just don't feel like you can think about anything other than your bladder. So I'm going to focus on bladders because I'm a urologist. So that is when we want to talk about surgery. So let's talk about it. The importance is the patient, the most important person in this whole discussion, because what you want to work out is what is it that you want out of it? What is your end goal? I had a patient who came in who said, all I want to do is sit through a show with my husband. That's all I wanted to do. We got there, and she was so grateful. She was crying, I was crying, husband was crying. I mean, it was just, it's about working out what the important focus is.
Did you do the surgery on her, did you, or not?
I did. Operated on her, but with something really fun, which we'll talk about in a minute. And the other important thing is understanding what you're having and why. You have the right to know what is happening. You have the right to know what the operation is. You have the right to know what the complications are and what to expect. All of that needs to be clear in your mind when you go down this path. You know, a lot of people come in and say, oh yes, I had this done, I don't know what it was or for, I think it was there. And you know, we get down to, where's your cut? Is it in your tummy? Is it below your tummy? Is it in your flank? And it's really important. Take control. It's you, it's your body. You're the linchpin, not the surgeon, even though we like to think we are. And always, always start low and go slow. That is my rules. You start something that's not very invasive and then work your way up, because if you feel like you need to. So don't ever jump into something really major. And if it makes you kind of go, ooh, that seems a big thing, take your time, step away, think about it, talk to someone else, get a second opinion, go from there. Okay, so I broke it down to a couple of different things so that hopefully it makes a little bit more sense. When we talk about incontinence, you can break it down to I can't hold it or I can't let go. So the can't hold it is pretty self-explanatory, isn't it? I can't hold it, so I leak. Can't let go are the people that can't empty their bladder well or don't have much sensation and they're overflowing over the top. So the approach is slightly different for both groups. So if you can't hold it, is it your bladder that's overactive? Is it your pelvic floor that can't hold everything in? Or have you had a radical prostatectomy if you're a boy? Or is it a combination of the two, which can happen often? So let's go through everything. So can't hold it, same rules, start low, go slow. And the start low in this case with operations is telescopic operations, cameras up the water pipe or the willy, and then you can do what you need to do. Then you do little minor open or major open. So let's talk about surgical things which are fun and maybe a little bit gross to see, I'm sorry, but endoscopic interventions are, as you can see, so it's putting a tiny little camera up your water pipe, and I've used a male because males have longer urethras, so I get better pictures. So you've got two types of cameras there. You can see one on the left here is black and a little bit bendy. So that's a nice flexible instrument that can be inserted awake. Don't freak out. It's under local anesthetic. It's like inserting a small catheter. Most people don't even feel it. Some people feel it like a little cramp. Mostly men get quite frightened by it, which you can understand because their urethra is much, much longer than a female urethra. The one on the right is the same instrument, so it's a camera that will take me into the bladder, but a rigid instrument, which allows me to do things with it a little bit more. You do have to be asleep for that because the caliber of it is much larger, and when you're doing an operation, it's always nice to have a patient that's not moving. So what can we do to help you hold it, help the bladder hold more urine? That can be done through a telescope. Anyone know what I'm showing you? Botox. I don't inject faces. You really don't want a urologist injecting your face. What we want to do is inject the bladder. So what we can do is put a little camera in. This is a tiny, tiny, tiny needle that you insert through the camera. That's the bladder wall, and we're injecting the bladder wall with Botox. What it does, it paralyzes the bladder muscle so it can't squeeze, takes away that sense of urgency, and often absolutely takes away the incontinence, particularly in my patients with spinal injuries or nerve injuries. It's extraordinary. There are risks, as with any operation. A small proportion of people, they might not be able to pee at all, so they go from being wet all the time to sort of holding. Can't go. So we make sure that you know how to manage that when that happens, because it's a temporary effect like Botox. It does tend to wear off, but it's fantastic for patients who haven't succeeded with simple measures like medications and dietary modification. And it does give you your life back. And that lady who sat through her show had Botox, and actually she ended up having a superpubic because her hand function was very poor. So, and that worked out beautifully. And in fact, she does very well on flights now because she doesn't have to go to an airplane toilet.
Yeah, right.
Now her husband is very jealous. So that's your simple, low, very easy recovery. Go home on the same day operation for a bladder that's overworking, so squeezing too much. If the bladder is really small and squeezing too much, and that's not working, which can happen because the bladder can lose its stretchiness. The next option is what I do, where you increase the size of the bladder with a bit of bowel. So it's like a patchwork quilt, but in your bladder. I take out a bit of small bowel, open it up, convert it into a U shape, open up the bladder, pop it on the top, sew it up, Bob's your uncle. And so, nothing to it. And what's nice is all it's doing, it's cutting the information pathways across the bladder, right? So we can't speak to each other to do the squeeze. And I've given you capacity because I've given you a little patch. So suddenly you go from a capacity of about 200 mils to a capacity of 700 mils. So my most recent augment, who I saw yesterday, walked on in and she said, I went out for lunch at 11, I got home at 7:30 and I didn't go at all. At which point I fell off my chair. No, you need to pee every 3 hours. But you know, it's just it's an amazing thing. Your capacity then increases magnificently. Again, there are complications. Obviously, when I tell you I'm taking a bit of bowel out, I'm joining the bit of bowel together, opening this, closing you up, that's not simple. And recovery can be complicated by a leak in any one of the joints that I've done. So be it bowel to bowel, bowel to bladder, or skin. So, and this sort of operation takes a little while to settle down. So after you've had it, really, I tend to try not to see them for about 6 to 8 weeks, because that's how long it's irritable. And once they come out the other end, I say, hey, how's it going? Really good now. So, you know, it's one of those things, because your bladder's had an insult. It's got stitches in it, it's got a new patch, it's not going to be happy. So, but it's a really good option if the others haven't worked, and if you think for you it's something your system can tolerate and you can manage. Some of them may not be able to pee or may not be able to empty completely, in which case they might need to self-catheterize. Is that something you can do? Is it not? So that's something to consider. So then we talk about can't hold it, pelvic floor. So what can you do? Let's talk about easy things through a camera. If you can't hold it, I'm sorry, I'm going away from the microphone, bad, and you're leaking down the water pipe. The simple idea would be, think about plumbing. I'm a simple plumber, block the pipe. So you inject a bulking agent at the top end of that pipe. So if you do that, you recover, you go home on the same day, recover very quickly, and for people with low volume stress incontinence works really, really well. And you can top that up every 3 or 4 years. So it's a day procedure, in and out, no cuts, done. So for some patients, very, very good. And for actually patients who've had a urethral catheter for a very, very long time, big, wide, open urethra, who are, say, very unwell, maybe even bedridden, and you know the leak can be devastating because if you have a pressure ulcer, the urine can really infect it. You can actually use a combination of putting in a suprapubic catheter, so you divert the urine, but you still have the problem of the big open urethra. You can inject to the bottom, so then they're continent. So without doing something that's hugely invasive, you can actually get them dry, comfortable, and safe. So that's a really good option for certain patients, well chosen. Slings. Who's been watching the news lately? Yeah, there's an extraordinary amount of excitement about slings at the moment. A sling is basically supporting the urethra, or a little hammock on the urethra, or your water pipe, to try and stop the leak from down below. Now, the problems that have been reported in the press, popular and otherwise, have been about the mesh that's utilized in making that sling. There are various types of mesh, but the one that's been the biggest problem is the mesh that's used in vaginal prolapse repair. So, and that has been difficult because the amount of mesh used is much larger, the area is much wider, the dissection is broader, and so it's very clear when you even read, there's been a Senate inquiry with the results were out last week or the week before, they separate out the two types of operation. We're not talking about vaginal mesh, which has caused such a lot of sadness and patient morbidity. We're talking about urethral mesh, which is a small sling which can be used. So if you're using that as a sling, it doesn't always have to be something that's synthetic. We can harvest some of your own tissue and make a mesh and that's from your abdominal wall, and that's called a rectus fascial sling, and that's there on the left. So if you're trying to kink the water pipe, you can do it with something artificial, which actually is a very quick, very easily recovered from operation. Again, no operation is perfect. There are complications. You may go into retention, that's when you can't pee. You may find that after you have the sling, the bladder is a little bit more irritable, so you might want to go a little bit more. But recovery-wise, very, very good, and as a successful treatment for incontinence and stress, really quite a good option. The mesh sling is, you were like, no-brainer. If the artificial sling is such a bother, why don't we all just go for a sling that we get from harvest from your own body? Well, on paper it's a great option, but the problem is it requires a bit more dissection. You need to put an abdominal incision, you need to dissect a bit of mesh out, then close up the belly, and if you don't have too much tissue, that puts quite a lot of strain in that particular mesh, and you may pop it, you may get a hernia down the line, and actually inserting it can be quite difficult as well. But it does very well for certain patients. If we can't sling it, we can put a sphincter in. Now, I must admit, I do this more for men than I do for women, and particularly men post-prostatectomies, have their prostate removed for usually prostate cancer, and their water pipe is widely open because the prostate is very, very close to the tap, the thing that keeps you dry. So in those gentlemen who are leaking or wet after the radical prostate, their water pipe has lost the ability to close off. And so what you're doing is artificially inserting a tap. So you have a reservoir that sits in the belly, a little pump that sits in the scrotum, and a cuff that goes around their water pipe, which is in a state of inflation all the time. You push the button, water goes from the cuff into the reservoir, opens it out, you wee, and it will automatically close off. It works out really well. The recovery is pretty good. You have about $20,000 worth of kit in your body, which makes you a bionic man, and
Interesting going through the airport.
It's all plastic. No buzzing. It actually works very well. Again, risks are that mechanically it can fail. So at about 10 years you might need to replace it. It can erode. And for some men, the actual trying to push the button doesn't work very well, and the button migrates. So, good option for certain people. Still incontinent, so we've gone, from this gentle process through to a sphincter. Finally, I can just take your bladder out, in which case you won't be wet because the bladder's gone, and I replace it with a little tube of small bowel, so that's bladder removal there on your right, with a little bag attached to it. So then you pee into the bag. That keeps you dry. Nothing comes out from down below. Or I can just close off the bottom end of the bladder, cut off the urethra or the water pipe from the bladder. So I'll just take off there, sew that up. But when I do that, what is the problem? Where's it go? That's it. I need to find a way of catheterizing that. So I build a new channel. So I'll talk about that in a bit as well. So close that off and build what we call a mitrofanoff, where I build a tiny little small bowel channel that comes out either here or into your belly button so nobody can see it, so you can catheterize and empty. I must admit I don't love closing off the bottom end of the bladder because I like having a belt and braces. So if there's an emergency and I can't get into the bladder through the channel up here, I like to know I can get in from down below. And most people outside of a high volume center would struggle to know what even that channel is. So they may not even recognize that. So it's quite nice to be able to get to the bladder through the pipe that people expect. So this to me is a very much a last resort, because I feel that I'm taking away a bit of safety when I do it. I can take the bladder out, I can build a new one. So I can either use large bowel or small bowel. Takes a bit of sewing, and I can either plug it, ideally not back to the water pipe because you'll keep leaking, and close that off and build you that exactly what I said, which is a mitrofanoff, which is just there, straight in. So you've got a bigger bladder, the bladder that is small, perhaps very small, too small for me to patch, are taken out, given you a whole new one. Are we still together on this journey? Good, good.
We're still in.
So that's a potted plan for people that can't hold on, depending on whether it's bladder, depending if it's pelvic floor, depending if it's prostate. So we'll move on to can't let go. So those people that can't pee completely due to whatever reason. Now I always say if you can't completely pee or your bladder's gone on strike and isn't pushing out the wee, there isn't a tablet that will set it off. And don't have a magic wand. So the only way to quickly and easily and reliably empty your bladder then is to bypass it. Simple plumbing. So you use a catheter. And when you're talking about not being able to pee, it's quite nice and wise to start low, less invasive before you become more and more invasive. And it's also important to talk about how you get to your urethra, which I'm sure you guys will talk a little bit about after me. So if you've got, it's like a pregnant lady, very hard to find the water pipe. You know, when that happens, you say, okay, you're not going to be able to self-catheterize, you get a catheter until you deliver. Could be difficult hand function. Could be that you can't actually bend because you've got back problems. Could be you can't position yourself on the toilet in a way that you can twist. So there are multiple things that might stop you from being able to help yourself, but something that you want to think about if you're talking about trying to get that bladder empty. So my preference, wherever possible, is for the patient to insert a catheter into the bladder themselves. Whenever I say that, my next line is don't freak out. It is fine, and it is okay. It won't cause any horrible things. I've got an 8-year-old that does it regularly. I've got a 16-year-old that does it, tucks her catheter into her bra, which I don't recommend, and does it when she's out and about dancing. So I don't think on the dance floor, but so it's a good way of taking control of your bladder. Then you can go, it's been 3 hours since I've last gone, I know, I'm going to head off to the loo, close the door, empty my bladder, done. You might find you're faster than a lot of other people in doing that, and you empty really well. And what's really good is if you have the problems of recurrent infection and you've got a bit of soup sitting around in your bladder all the time, you're sort of taking that out of the equation. So that is a good option. Now if you can't do that, then it would be a permanent catheter if we're talking catheters. And you can have them either through the belly, which is a suprapubic catheter, there on the right, or through the urethra, there on the left. My preference of the two is the one through the belly. The reason, comparatively, suprapubics have a lower infection rate. The changes are much easier because you're lying down in bed, you've not got your legs up, you're not getting your external genitalia out for all and sundry, and it is a nice way of ensuring your bladder is draining well. If that is not palatable, because it does involve having an incision, having a catheter in place, then the alternative, I think, is a urethral catheter. In time, if you have a urethral catheter for the men, it can erode the head of the penis, and I've seen penises flung open like that, and it's just heartbreaking because it's quite a difficult thing then to reconstitute. And in women, the urethra can just become really wide and patulous, so really big and wide, where you just cannot get it closed properly, so you're hosing around the catheter as well as through. And then that's a real difficult surgical management issue. And of course, like I mentioned before, I can build a mitrofanoff. I can either use a bit of appendix if you've still got it, and if the appendix is patent, and if not, I'll borrow 2 lots of 3 centimeters from your small bowel and build a tube, and then plug it to the bladder and then to the skin. Nice thing to catheterize, nobody knows you've got it, and if you do it through a fan and steel and a belly button, nobody even knows you've had an operation. Finally, if you can't pee, and we know that it's because your bladder is just not squeezing everything out, and that's your problem, you can stimulate it. How do you do it? It's kind of like giving a jump start to your back nerves, basically, and you do that by inserting a little wire through the sacrum into the nerves, into your pelvic plexus, which are the nerves that feed your bladder. Attach it to a battery, and then you have something like a car remote in your hand. that you can whir on and off that'll keep it stimulated. So basically, if you can work a car remote, you can work one of these. It's very easy, and the battery is about this big, and it's inserted under your bottom there, so it's not in the way. The only thing is, if you're doing a very physical job, doing lots of heavy lifting and moving, that becomes a problem because the wire can displace. If you have a problem that requires repeated MRIs, MS for example, you can't have it because you can't have an MRI with the battery in place. But it's a really great way of getting a bladder that's gone on strike to start working really, really effective. And actually, it works well for people with fecal incontinence and urinary incontinence as well. We don't know why, but it seems to. There's some sort of messaging that goes on at the nerve level. Nobody knows how as yet, but it does work well. So that's really a lot, I feel, of trying to hold, not hold, and the sort of huge amount of operative intervention that's open. So there is a lot that we can do to get you to a better spot. Most people don't need to go into those extreme levels of intervention, and it's really important when you go in and you're considering an operation that you really take your time in making certain that you understand what you're getting yourself into. And if not, ask questions. And if you're not getting the answers, ask again. It is your right. And do all the basics first. You might not need me, my horrible scalpel. And that's it, really. Thank you very much.
Very good.
Any questions?
I'm going to say a little thank you and give a little gift. Unfortunately, it is red wine, but
We hope you enjoyed this recording today. If you haven't seen the others, remember there are 5 in the Arthritis Below the Belt series, and we have a number of interesting other screencasts available on our YouTube channel. Please see the screen for details of ways to contact us, whether that's through our advice line, Facebook, Instagram, website, or even Twitter.